First of all, welcome to Cosington Park Leisure Centre, which is a new leisure centre for Medway Council, replacing the old splashes. So we're delighted to be in what is an eco building of a high standard. Feel free to have a look around after the meeting. We're going to be connecting up with a new community allotment in the nearby park. There will be a tree nursery, there will be a cafe, all part of our sustainable healthy living strategy. So notwithstanding some financial wobbles along the way and bitten nails, I think overall we're pleased to be here, acknowledge that the former Conservative administration started this project. Would that it had cost less, but it's here. And we're hoping that after the formal opening for the public, everybody in Medway will be able to enjoy this facility. So I'm going to hand over to Stephanie for the election of chairperson, because this is the new Health and Wellbeing Board for this year, and I'll speak a bit more about that when the election's done.
Thank you. Can I just have a nomination for chairperson, please? Okay, can I have that seconded? Thank you, Councillor Price. We also have election for vice chairperson today. Can I have a nomination?
I would like to nominate Jane Back from Medway Maritime Trust. She's not here today, but she has expressed her willingness to be our vice chairperson again.
And can I have that seconded as well? Thank you very much. Over to you, Councillor.
Okay, thank you. So as I said, this is Hello, Councillor Peake. Eddie, sit yourself down. That's okay. Yeah, there's a place for you. After that short report on Eddie's well-being, we'll start again. I'm glad that he's here. That's a good thing. And thank you, one of our visitors. Thank you very much. Much appreciated, Katie, for... I can't apologise for the rail service, but I'm pleased that you've managed to overcome the problems that you've had. We've only just started, so welcome, and thank you very much for coming and making an even harder effort to get here. So this is the new Health and Wellbeing Board for the municipal year 24-25. Last year, when we started as the new... Good afternoon, Councillor Jones. Settle yourself down. As the new Labour administration, we had a refreshment of the board, so that we wanted to avoid it becoming another scrutiny committee, which is what it's not supposed to be. It's a mandatory body, a collective of partners working together to make sure that every single person who's around this table can make a contribution to the issues and problems and ideas and innovations that come through the board to help get rid of health inequality in Medway and improve the health and well-being. So it's an important reminder. We had a really good development session, those of you that were able to join us, with the Local Government Association, which was helpful, and we've had themed meetings, another one today on women's health, and I think we feel that the board is operating well. We've had great attendance, and hope that that's going to continue this year. I want to register. So if you haven't been here before, welcome, and I hope that you'll feel that you can come again. And I want to register my thanks to Councillor Hackwell and to Councillor Edwards, who were on the Health and Wellbeing Board last year, and welcome Councillor Lawrence and Councillor Jones. Okay, so thank you very much to those outgoing councillors for their work, and thank you, Councillor Lawrence and Councillor Jones, for stepping forward. Now, the next part of the agenda, I'm going to pay tribute to our Public Health Director, James Williams. You can see James there on the wall above, hello James, above a lovely word cloud that was made by the team in Public Health as part of their tribute to him. James died after a short illness, and we miss him very much. Lots of tributes have been made to him, including right across the country from the public health family itself, from the health family, from many of our partners. But I just wanted to talk a bit about him today. And where it says be more, we're saying be more James. So James joined the council in 2017. I was on his interview panel. He came bounding through the door with a big smile that was there for ever after. Wooed us all, collectively, cross-party, with what was a unique and very sincere kind of grassroots approach to public health and improving the health and well-being of people for Medway. And I think we collectively, when he very sadly died, felt he was one of the best appointments that we'd made for Medway. He had a non-traditional background for public health, having served in the army and then also been an Olympic fencer. So he had a very personal, sorry, my phone is vibrating, which is not helpful. He had a very personal commitment to staying fit, but he never shared that in any kind of a superior way. He shared his fitness, his experience, his ideas in a really humble and encouraging way, and made everybody who encountered him feel that he cared about them for the very good reason that he actually did. Our loss is no greater, huge though it is, than his wife Marie and their daughters Lauren and Amber. We were absolutely thrilled and overwhelmed, all of us, to see 500 people, some people around this table, attend his funeral at Rochester Cathedral. And, you know, I can say to you today, the family are really grateful for the kind of love and support that was shown from the Medway community for James, and for the 3 huge parts of his life that were told as a story through some lovely tributes at the funeral. He spotted the talent in our public health team. He encouraged them and brought them forward to what they are today, an award-winning, enthusiastic team with national repute, particularly for public health, intelligence and research, and indeed for some of the community work that we do. We were nominated for 3 LGC awards just a couple of weeks ago and went together. We didn't win anything, but we were pleased to be finalists, and the colleagues here brought along a photograph of James that we were able to have on our table and talk about people. We don't want to forget him because he made such a huge contribution. And I've said many times it was honestly like working with a really nice brother who cared about you and shared your aspirations. And I was not the only one, by any means, who felt like that. And he treated everybody as an equal. He loved a natter. He was famous for talking about the shenanigans of other people, a word that we all associate for James. And we miss him terribly. But I know he'd want the board to continue to be a success. And I'm very pleased to be able to do a tribute for him today. It won't be our last one. We're thinking very seriously of making a lasting tribute in our community facilities to him, because he gave a lot to Medway. And yeah, there we are. Thank you very much, everybody. So I think anybody, we will, because it's the first Health and Wellbeing Board of this year, I'm going to ask you to introduce yourselves so that people around the table know who we are. And as we go through the presentations, I'll be really pleased to be able to hear your questions and ideas. Women's health is a hugely important issue, and I will be very interested in anybody's contributions. So if I start with you, Adam, please, and then we come around the table this way. Steph's saying, can you use your mic? So it's quite a big room.
Did you want me to do that again? Good afternoon. My name is Councillor Adam Price. I'm lead member for Children's Services at Medway. Thank you.
Hi, Martin Riley. I'm the SRO for Medway and Swell Health and Care Partnership, and also the Managing Director for Medway Community Healthcare.
Thank you, Chair. I'm Councillor Mark Jones. I'm the member for Strood West Ward on Medway Council, and whilst I'm speaking, can I apologise for slight lateness? I've been at a meeting of Kent Pension Fund in Maidstone and I had to travel back, so thank you for bearing me Chair. Thanks.
Hi, Aparna Bilapurkar. I'm the Chief Allied Health Professional Officer in Kent and Medway ICB, and I'm also the SRO for the Women's Health Hub programme. Thank you.
Hi everyone, I'm Malti Varshne. I'm Director of Strategic Change and Population Health in the ICB. Thank you.
Hiya, I'm Kerry Bright. I'm Service Manager for Oasis Domestic Abuse Service.
Hello everyone, I'm Lisa Watson. I'm an advanced nurse practitioner and menopause specialist nurse at Medway Practices Alliance GP Surgery. Thank you.
Oh, hello.
If I can just say thank you very much for doing that for us, Jane, and thank you all for coming, because at every board we try to invite visitors who might have a very direct interest in what we're discussing. So I'm really pleased to see you here today and look forward to your contribution.
Assistant Director for Adult Social Care here at Medway Council.
Hi, I'm Ailish Geldenhuis. I'm Strategic Head of Public Health.
I'm David Whiting, Acting Director of Public Health.
Afternoon, everyone. I'm Leanne Farrick. I'm the Director of People and Deputy Chief Exec of Medway Council, and I am also the DAS for Medway. Thank you.
Stephanie Davis, Democratic Services Officer.
Hi everyone, I'm Tass Alder and I'm Projects and Engagement Officer over at Healthwatch Medway.
Hello, I'm Anne-Marie Jordan. I'm with TAS today for Healthwatch Medway. Thank you.
Hi, I'm Leah Elliott. I am the Clinical Services Manager for Integrated Sexual Health for Kent Community Health Foundation Trust.
Good afternoon. I'm Councillor Eddie Peake.
Good afternoon. I'm Councillor Simon Curry. My ward is Luton in Chatham, and I'm the portfolio holder for climate change and strategic regeneration.
Hi there, I'm Caroline Rickard. I'm a GP and work for Kent Local Medical Committee as one of the medical directors.
Hi everyone, I'm Katie Town and I'm a Senior Public Health Intelligence Analyst at Medway.
Hello, Andrew Lawrence. I'm a Conservative councillor representing Hempstead and Wigmore.
Hiya, I'm Kerry North. I'm representing Streetlight today. We work with women who are being sexually exploited.
Good afternoon, everyone. I'm Rupa Sen from Medway Diversity Forum. I'm the Executive Manager, and I'm representing all the ethnic minority community groups here today. Thank you.
Thank you very much, everybody. You can see we've got an august and experienced group of people in the room today, so I'm really hopeful that when we hear what's happening with women's health, you'll be able to make some great contributions. So I'm just going to give apologies for absence. I've got apologies from Councillor Tracy Coombs, from Raj Bakada, who's the Interim Assistant Director of Adult Social Health, from Adult Social Care, thank you. From Andrew Stradling, who's our Interim Medical Director at Medway and Swale Health and Care Partnership, from Paul Bentley, the CEO of the ICB, and from Jane Black, as I've already mentioned. And we have also received apologies from Adrian Richardson, who's the Director of Partnerships and Transformation at Kent and Medway Partnership Trust, the Mental Health Trust. So can I ask, first of all, for those of you that were here, is the record of the meeting on the 11th of April correct, please? Thank you. I haven't got any urgent matters. Are there any direct relations of disclosable pecuniary interest and other significant interests?
Chair, just for the record and on officer's advice, I have to declare an interest because my wife works for East Kent Hospitals.
I've already declared as well, but my husband works for Kent Community Health Trust, and also I am a shadow director or shadow NED for one of the voluntary trusts in Maidstone. Thank you.
So we're now going, and can I say as well, look, there's tea and coffee and water in the kitchen. Just get up and help yourself. If the kitchen's directly behind us, there's some snacks in there as well. So just get up and help yourselves. And if you're comfortable or uncomfortable with the air conditioning, which I think today we're all pleased to have, just let someone know. And yes, you're a bit cold already. Okay, thank you. So if you just turn it down, up, I suppose, as far as that's concerned. That's all right, Jane, because I know it can be a bit overwhelming. Okay, so we're bringing together different partners to discuss the women's health strategy being implemented locally, and we're going to have some presentations now. So, are we ready? Yep. Oh, okay. Sorry, we need the computer, so we need... If anyone gets too hot, let us know. We've got to get used to having the luxury of climate control. Okay. So we need you back. Now Dan's back. First of all, we're going to set the context and have an overview and some statistical information of the National Women's Health Strategy and how we are aiming to address the key issues identified.
Thank you, Councillor. So I am, as Councillor says, just going to give an overview of the National Women's Health Strategy, which all of our work should then flow out of. And following this brief overview, Katie will give us some insight into the data, both at a national and local level, and what the challenges are that we might be facing. So first of all, why do we need a strategy for women in the first place? And whilst we know that women do typically live longer than men, they do spend significantly greater proportion of their lives in ill health or disability. And when they were doing the research for this strategy, they found that women's voice is often overlooked, and therefore a male lens is often applied to research and clinical trials, for training that's in place for healthcare professionals, and in the design of healthcare policies and strategies. And what it meant is that we've got a gap in the data and the evidence around not just women-only conditions such as menopause and endometriosis, but we also now know that there isn't enough known about those conditions that affect both men and women, but may affect women in a different way. For example, cardiovascular disease, dementia, and even some neurological disability conditions. So the government has set out a 6-point plan to try and address these inequalities, with the ambition being to increase health outcomes for women and to improve how health systems listen to women. And the way in which they say they're going to do it, it's not really rocket science. What they're saying is that they're going to increase the outcomes by addressing needs across a life course, so taking a life course approach, by making the woman the focus of policies, by delivering wraparound care for women, and, as all our mothers have told us, by listening to women when they're making changes and designing services. So, next slide. Thank you. So, as I said, this is the how. They think by ensuring women are heard, we'll be able to tackle some of the stigma and taboo, and we'll also be able to ensure that they're listened to by all professionals, and women's concern about their own health will be taken more seriously. They want to ensure that women can access reproductive health across the life course and understand how those conditions affect men and women differently. They want to ensure that a woman's age, ethnicity, sexuality, or disability does not impact on her outcomes. They want to ensure that there's not just initial but ongoing training for healthcare professionals to be able to treat patients knowledgeably and empathetically. And by normalizing taboo subjects such as menopause and periods, they believe will be able to ensure women are able to remain productive in the workplace for longer. And finally, they want to address the lack of research into women's health conditions. The strategy sets out these 6 priority areas. So the 6 priority areas are menstrual health and gynecological conditions, fertility, pregnancy, and pregnancy loss and postnatal support, menopause, mental health and well-being, cancers, health impacts of violence against women and girls, and health aging and long-term conditions. It's been set as a 10-year strategy because what they believe is that success will depend on long-term cultural and systemic changes. And for time's sake, I'm not going to go into details about each of these areas, but the strategy is very clear on why these were chosen as the priority areas, what the 10-year ambition is for each one of these, and what is already underway within the strategy. So I'm simply going to summarize now with this, which gives you a pictorial demonstration, a visual demonstration of how they're applying a life course approach against women's health. I realise this might be quite difficult to see on the screen, but it literally just breaks it down by age across the life course, and then the different conditions and areas that we should be considering about within women's health, with the thematic principles underlying all of that. And that's a very brief summary of the national strategy and where we are with it at the moment.
Thank you very much, Ailish. I'm going to move to the next part where we're going to see some key data so that we can set the context, and then in between the presentations, after Katie's presentation, I'll open it up for questions. Okay, so thank you.
Right, so thanks for having me here today to talk a little bit about the data on service access and uptake in women's health in Medway. Next slide, please. So I'll just start by giving some Medway context. I know Ailish has already touched on this already. In 2022, there was around 282,000 people living in Medway, and out of these, around 51% were identified as female at birth. So within this female population, someone could expect to live to around 82 years old, which is worse compared to England. Out of these 2 years, on average, 64 will be in good health and free from disability, a potential of around 18 years in poor health or disability, a quarter of a woman's life. This highlights the importance of good access to women's health across the life course, which is the purpose of the Women's Health Strategy. Next slide, please. So these are just some of the topic areas we'll be covering today on service uptake across Medway. It's not an exhaustive list, it's just some of the topics that, in the abundance in women's health. In each of these, there are key barriers into accessing these services, such as living in an area of deprivation or the impact of COVID, amongst others. And that as we go along, the topic we're discussing will be in the top left corner. Next slide, please. So we'll start on early prevention side of things with the HPV vaccination, which protects against cervical cancer. Cervical cancer is the 4th most common cancer in women globally and one of also the most preventable. And the NHS have a goal to eradicate it by 2040. The latest data shows that despite Medway's coverage being better than England, there is a national and local decline over the last few years, which is now lower than 10 years ago. And around 1/5 of girls were not vaccinated for HPV in 2022/23 in Medway. One potential explanation for this is the impact of COVID due to HPV being primarily brought around in schools and also by the GPs, but there are also other barriers such as communication with parents over what it is and the importance of it. Next slide, please. Similarly, coverage for women's health screening, such as cervical cancer and breast cancer coverage, has also been declining in Medway, especially since COVID. In Medway, cervical screening coverage between the ages of 50 to 64 is now worse than England at around 73%. In the younger age group, the coverage is around 5% lower, despite it being better than England. This is important to consider because young people, especially those between the age of 30 to 34, are at the highest risk of being diagnosed with cervical cancer. And research has suggested this may be due to feelings of embarrassment or a lack of understanding, again, in the younger age groups. And for breast cancer screening, coverage is now worse in England at just 64%, with a third of eligible women not being reached. Next slide, please. So one of the key sexual health services to highlight, and also highlighted in the Women's Health Strategy, is long-acting reversible contraception. This is a form of birth control which helps to prevent pregnancy after one treatment, such as the coil or the implant, and is offered by GPs and sexual reproductive health services. In Medway, this is particularly important as we have a higher rate of abortion, higher than England at around 22 per 1,000 women. The plot presents the rate of LARC prescription by year and service type, showing that the impact and decline again in 2020 with COVID. For GPs, the rate has not returned to pre-pandemic, but for sexual reproductive health services, it seems to have. National statistics also show that these rates are significantly lower in areas of high deprivation, and that women in these areas are disproportionately affected by lack of access to GPs. Next slide, please. Another area of women's health which is impacted heavily by deprivation is access to maternity services, for example, being booked onto a personalised care plan throughout pregnancy. The National Maternity Survey in 2015 suggests that women living in the most deprived areas are 60% less likely to have received any antenatal care at all. To assess this in Medway, the bar plot shows that the percentage of mothers booked by Medway NHS Foundation Trust in the purple bar is relatively proportionate to the percentage of births in Medway, which is the grey bar, by mothers' deprivation decile. You can also see that there were both more births and more mothers booked onto MFT who live in areas of higher deprivation in deciles 1 to 4. This could suggest that we are potentially meeting the need for services. However, it should be noted that this does not say anything on the quality or the continuity of care provided after initial booking. Next slide, please. The Women's Health Strategy also highlights that fertility services and pregnancy loss services are particularly important. For both of these, there is a lack of published and publicly available data. For fertility services, this is something that the Women's Health Strategy has made as a priority, especially for same-sex couples who do have access to IVF treatment, for example, on the NHS. For pregnancy loss and birth trauma, the main service for this around Kent and Medway is the Thrive service, which offers mental health support for women and their partners who deal with difficulties after birth trauma and loss. And they found around 60 or 14% in the last 2 years were from Medway and Swale. Next slide, please. As mentioned by Ailish, a particularly under-researched area of women's health is the menopause. This is a natural part of ageing that occurs usually between the ages of 40 to 60 and can cause debilitating symptoms in up to 1 in 4 women. One of the most common and increasingly common treatments for this is hormone replacement therapy, which helps to relieve these symptoms of menopause. And the cost to this was actually reduced in April 2023 in order to improve access. The impact of this can be presented on the table from the Kent and Medway ICB, which suggests that in Q1 of 2023 alone, year to date in June, there were over 20,000 more patients reached than there were in 2015/16 at all. Next slide, please. Moving on to mental health, which is relevant across all stages of a woman's life. Data suggests that 1 in 5 women will experience a common mental health condition, such as anxiety or depression, and this is actually compared to 1 in 8 men. The NHS offer improving access to psychological therapy or IAPT treatments for this, which provide short-term support for common mental health disorders. One of the key ones in Medway is the Medway talking therapies, and an overview in 2022 and 23 showed that there were more women reached than other genders. It's important to highlight, however, that out of these, a very small number were individuals who were living in areas of high deprivation, and this is especially important as these individuals living in these areas are shown to have higher likelihood of developing common mental health disorders and are less likely to access support. So this could be an area of particular need. Next slide, please. And finally, in terms of physical health, the leading cause of death in women worldwide is cardiovascular disease. One of the main services in order to help prevent this are the NHS health checks, which identify those at risk of conditions such as heart disease, diabetes, kidney disease, and stroke. And it's available for people between the ages of 40 to 74. So in terms of health checks coverage, Medway is actually doing better than England, with around a 31% coverage of the eligible population since around 2016. In 2023 and 24, Medway Council and pharmacies, not including GP surgeries, reached more women than men and other genders, and the most common age group was 60 to 64-year-olds, and the least common was 70 to 75-year-olds. Right, that's the end of my presentation. Thank you.
Thank you very much, Katie.
Thanks.
Now, as I said, because Aparna needs to leave, I'm going to ask you to do the presentation, and then we'll have, so I'm just changing the order slightly there on women's hubs, and then we'll have some questions before we go to the other presentations. Okay, thank you.
Thank you. So I'm not going to repeat what Ailish has already talked about, and Katie, kind of thank you for presenting the data. My data is no different, but it's kind of Kent and Medway wide, which I'm going to just touch upon. But I just wanted to sort of say, following the publication of the National Women's Health Strategy, there's a group that's been set up nationally, which has DHSC involvement as well as NHS England, and we meet regularly on a monthly basis as Women's Health Champion, and the core specs in terms of the priorities for what needs to be delivered as part of the funding. So NHSC has provided each ICB around 600k, which is around approximately 595k, which has come to Kent and Medway ICB. And there's an expectation that the core specs, which were developed through this wider engagement, will need to be delivered as part of the Women's Health Hub agenda. And this is a non-recurrent funding. It is a funding that came to the ICB last year. So it's 23-24 and 24-25. Following the publication of the strategy and the publishing of the core specs, NHSE have kind of highlighted that in the operational planning guidance as well, that and with letters that have come to the accountable officers and chief execs in the ICB, that Women's Health Hub need to be up and running by July. So there should be, as part of the ask, there's a requirement for at least one Women's Health Hub to be up and running by July that would deliver at least 2 of the core specs that have been published by them. And I'll talk about the core specs in a minute. And the expectation that the Women's Health Hub should deliver all the 8 core specs identified by this group by December. So there are about 8 core specs which span women's health, the lifespan. They include LARC, which includes both contraceptive and non-contraceptive LARC. It includes pessary fitting and removals. It includes menopause, advice, guidance. And I wanted to just mention about HRT. So HRT is just one of the many means to support women who are going through menopause symptoms. A lot of women do choose not to go for HRT. So one of the things we are asking is that advice and guidance is provided by the Women's Health Hub around alternative therapies as well. And we will try and understand how that information can be captured. And cervical screening, so that's fits really well with the information data that Kate has presented. Menstrual problems, that includes endometriosis, etc. Preconception care, breast pain assessment and care, and screening and treatment of sexually transmitted infections and HIV screening. There are 3-4 other areas that our women's our population and our women have raised that they would like to be seen to be delivered within the Women's Health Hub. So we have used a triumvirate approach to look at what we need and how the Women's Health Hub can be be facilitated within Kent and Medway. There was a Women's Health Engagement Forum that was held last year, and our communications team they were involved in pulling together a survey, and the survey was done across Kent and Medway wide. And we had approximately about 850 women who responded to that survey. And we also had a focus group one of the evenings, and we had our public health partners as well invited as part of that. And we had first-hand experience of what women felt about access to services, access to women's health services within Kent and Medway, their experiences around the quality and how they felt the clinicians were approaching them. So if they had gone to GPs, what their concerns were, etc. So we pulled a summary together in terms of what our population needs are. And of course, we know areas of deprivation across Kent and Medway, and of course know that Medway and Swale, and particularly DGS and East Kent areas, there are pockets of high deprivation. So one of the asks from the Women's Health Hub was to consider what our women have also asked about. And some of the asks were around GPs having the knowledge and skills and training to understand women's health issues better, so that they wouldn't have to go through convoluted pathways into secondary care where things could be managed closer to their homes. So if they were seen within the primary care services, etc. So that was a very, very strong voice that came, around the access of services. One of the other things women talked about was also around the GP listening to them. So if they needed additional support, for example, pelvic health support, etc. Again, if those could be provided within a primary care setting. So having a one-stop shop. Now we're aware that a lot of that requires a proper setup, etc. But that's been put in as one of the potential criteria for what we would be looking at from the Women's Health Hub. So following this, and I think just fair to mention that the subsequent slide talks about the 10 objectives, which talks about better access, high quality services to be delivered through the Women's Health Hubs, improving patient experience, improving women's experience of, through providing them potentially one appointment or getting everything done within one appointment or a smaller number of appointments. It's about access to health information, whether that could be done digitally or it could be done through using other media and other comms channels. Screening and treatment, again, linked with all the core specs, and improved workforce and skill mix. So just mindful of the fact that we do not have as many GPs. We know that primary care workforce is under a huge amount of pressure, but we do have a lot of other professional groups that work within women's health services, that include nurse practitioners, that include pelvic health, allied health professionals. It includes health coaches and champions that are already working within wider public health services. that could be drawn upon, and you've got public health consultants, etc. We do need to kind of maximise the utilisation of the wider workforce and bring them on board to sort of support that sort of lifespan, sort of like, support across the life cycle of women. So, and of course, efficiency. Now, mindful that, again, this is a non-recurrent funding. So one of the asks from the Women's Health Hub would be, how do you make those services sustainable? That also means they would have to think about potentially any increase in demand, how they would work with our ICB and local authorities, given that there are financial constraints across all the organizations. So how do they kind of like, demonstrate that sustainability through the existing or maximizing the use of existing resources and existing upskilled resources is what I would kind of like, emphasize. So there are these sort of objectives that we would expect from the Women's Health Hubs. Now, following that, we set up a stakeholder group, which includes both our local authority partners. I get Steve to attend from here, from Medway, and I've had a number of engagements with Charlie as well, as public health consultant, kind of like working together, as well as Kent partners, and we've got secondary care partners, we've got our PCN partners across the wider HCPs, and a number of other people who are kind of involved in the stakeholder group. And we've kind of gone down sort of the route of creating a criteria to what we would be looking for in the women's health proposals. Given the challenge with time, that we are nearly in July, and we needed to kind of get the hub up and running. We also understood that potentially we're not talking about creating a large infrastructure, a new build around Women's Health Hub, but potentially looking at how these could be delivered within the PCN settings or in community settings. So we left it open to the the ask from the group and from the PCNs were that actually, if you want to kind of put yourselves forward to provide that sort of like that service in a hub format and in a hub and spoke model perhaps, then we are expecting X, Y, Z as a criteria, and some of the criteria include the 10 objectives and what is expected by July and what is expected by December and beyond. So we are absolutely kind of asking for more innovation, but also saying that let's not be restricted to the 7 or 8 criteria that NHSC have set up, but actually look at sort of wider areas around advocacy for women, women who have gone through sort of domestic violence, etc. How do we use the hubs and how do we use the comms channel to knit through across the pathway? So that was the ask from the PCNs, and it was widely socialised so that they could put their proposals in. I'm really glad to say the challenge was taken up really well. We had 4 proposals that came to us, and we set up an evaluation panel, and we had all the members represented at the evaluation panel, including our local authority partners. So Steve was part of the evaluation panel, including Malti, who was kind of sat. So we all wore different hats on, and there was a very clear objective criteria for scoring of the proposals. So following that process, we have agreed that in the interest of time and in interest of how the proposals seem to be, provide the assurance that they would be ready, up and running by July to deliver at least 2 of these specs, we have agreed to fund 2 of the proposals for now, for July. And the plan is for the other 2 proposals, because we do not want to disappoint anyone given the passion and the enthusiasm that they have presented, because it's only going to help with sort of reduce the health inequalities across Kent and Medway. We want to support them as well, but we want them to demonstrate and strengthen their proposals to sort of see how they would work with all the wider partners that include local authority, that include secondary care, that do include how they would engage with women within their areas to understand the real needs and not just focus on LARC, because LARC is just one element of the whole Women's Health Hub and that core spec. So it's work in progress. We're still kind of we've made a conditional offer to the 2 to the 2 sort of bidders or the areas where the proposals have come from. And I'm working very closely with them to kind of make sure that they have addressed the clues which came from the evaluation panel. And we're going to get some revised proposals, some revisions to that by next week. And we're hoping that we'll get the MOU signed off by next week. And that would include local authority partners to kind of agree with the MOU as well, because we want them to consider what it means in terms of impact on the demand for services, but how they would cater to the demand and how they would ensure that the services would be sustainable going forwards. As part of this whole process, we've also set up a governance forum. So we've got a governance group. I know we haven't got, there were charts in the slide pack. I'm not going to talk about through all that detail, but we do have governance forums which include local authority partners, all the wider stakeholders, and we'll be holding the delivery of the hubs and what the core specs would be delivered within the hubs. We'll be holding our bidders to account to ensure that they are delivering what they said they would set out to deliver. And that would provide an additional level of assurance as well, because there would be metrics, both qualitative and quantitative metrics, that would include how they are engaging with their population, local population, as well as some of the quantitative metrics that Katie just presented. So we do want to sort of see an increase in perhaps the advice and guidance, for example, that's provided to women who are undergoing menopause, including potentially an increase in HRT, but also an increase in the LARC, both contraceptive and non-contraceptive uptake. And we should start seeing sort of some reduction in some of the referrals that go into secondary care, if that could be provided within the Women's Health Hub setting. So this is just a start, and it's not a huge amount of funding, but we are hoping that through that networked approach, and it's actually what's been great about this, the program is it's got people talking to each other. It's got the PCNs talking to each other. So just this morning, because I was taking a call back from one of the, from DGS, which is kind of won the bid, they said, from Kent, East Kent, someone has reached out, one of the other proposal bidders who were not successful have reached out to sort of see how they could work together. And I think this is brilliant, because this is exactly what we want. We want people to talk to each other across Kent and Medway and understand how we could sort of have that wider service offering, and that includes how we communicate back to us to our population, but also look at how we work with secondary care as well, and sort of see this is just the start, I think, and I think we could do much more, but let's take one step at a time is all I say. Because the group gets really enthusiastic and starts talking about, let's bring the one-stop shop, let's do Urogyney clinics within primary care setting and the Women's Health Hub setting, and I'm like, we'll get there, let's just get this started, and so that's all I have to say.
Thank you very much, Aparna. Before I open it up for questions, are we permitted to know where the two hubs who've had conditional offers are?
So yes, it's work in progress, but I can say, because we have let the hubs know, both the successful ones for July, I say, so the two successful ones, one is in DGS and the other one is Thanet Kick. They're both in Kent. We did have a proposal from Medway. We've asked them to strengthen that proposal and come back to us. So we are hoping what we've written to the other two, which are, another one is also in Kent, we've asked them to strengthen their proposal, and we're looking at potentially a September start. That gives them enough time to kind of pull together the resources, etc. they would need.
So for this board, obviously the Medway one is a huge priority, and I'm afraid the statistics speak for themselves, don't they? Just a few comments from me. We've got a lot of work to do with screening, and as part of our council's strategy of prevention, a thread that we want to run through every single part of our services, that's critical. So I think we'll be perhaps looking together at the way we weave that in through our own health and wellbeing strategy, and absolutely through our own publicity, because something is going pretty wrong there, isn't it? I'm appalled at the national statistic of 60% receiving any type of antenatal registration. I'm pleased to hear that we're doing better than that in Medway, but that is a shocking statistic, actually. And I think we have to collectively accept that and think about how we change that. There are lots of things here that have been through scrutiny before, and I don't want to jump over the things that we're going to hear, IVF being one of them, a lottery, frankly, with very little funding, and I think we need to think about how we rebalance that. It's good to hear how well we're doing on health checks, but I hope people around the table can see, we're doing better than other people at 32%. There's a huge amount of people who are not coming forward for those health checks. And we have got facilities to offer them. We can do them quickly. We are reputedly and practically good at them. But I think we've got to, you know, like as with so many things, and as colleagues from the voluntary sector will often hear me say, we've got to make sure that every single person who can be helped is directed towards what's on offer by every single person they encounter when they call for help. And that's something that, you know, we need to weave into what we're doing. So for us, as a message for you to take away, Aparna, the Medway Hub is a huge priority. We have got extreme deprivation in some of our wards, and as I say, the statistics speak for ourselves. So any support that we can give from our public health team to making sure that that proposal gets the funding. And just finally, because the funding is non-recurrent, what is your expectation about how the hubs are going to keep going when the funding runs out?
So, as I said, I'm not a commissioner by background, particularly for this piece of work, but I know that this discussion has come up again and again. But one of the asks, and I can give an example of how another sort of hub has proposed that they have looked at how they can generate income through the additional demand, etc. But we are still querying what that sort of additional demand would mean in terms of fallback option for ICB and local authorities, because I understand local authorities fund the contraceptive lark, for instance. But if we're looking at sort of them getting the demand up, if they are kind of consolidating the services within one area, then perhaps that makes it sustainable. While, you know, if it's still kind of like, you know, within the funding bracket. One of the things we did sort of have discussion on, and I had discussions with Steve and Dirk from both the councils, is areas, what we need to kind of understand is, like, there has been a drop certainly from contraceptive lark perspective. We saw a little bit, I've seen a little bit of a drop in the uptake of that lark. And I think even if we can bring that up to the levels that were there pre-pandemic, I think that would be important. And then anything beyond, we will have to keep working with the women's health, the designated women's health, up to understand if there are further commissioning discussions that need to be had with the ICB and, you know, work in that collaborative space. But I think beyond that, I'm not able to commit to anything from the ICB commissioning perspective, but I know that there are contracts that are being reviewed from a non-contraceptive lark perspective from the ICB, and it will, I understand it, my understanding is they've assured me that it is going to be funded, it might just be in a different way.
We'll have to be lobbying for that because, you know, lark is critical. It's very sad that we've got more women in Medway going through the trauma of having a termination than other people have, and that is something that we need very much to work on. Okay, so we don't know really the shape of the sustainability, but we're hoping for it. My final comment is on the 10 developments, you've got a very optimistic prospectus there that they're all deliverable by December. And I suppose not necessarily now, but perhaps for the board, some detail on that assumption would be helpful, because I think that looks a big ask, actually.
Yeah, the 10 objectives have been set by NHSC and they're non-negotiable. What we did do is, as part of the seeking of proposals, was set that within the criteria. So we've actually shared our criteria, evaluation criteria, with the wider team, because we are probably the only ones who've actually done that to measure against, because it just makes, in some ways, it made our job easier so that we could actually kind of like, you know, rank our proposals against those, but also it gives people to, you know, enough time to think that actually they do need to deliver X, Y, Z as part of the commitment, and it's not just about lark. In fact, some of the proposals got marked down because they were only focused on lark initially, and we want to kind of get them to think wider. So, as I said, like, you know, we don't want to, you know, we want to include and approve all the four proposals, because we've seen, I mean, I've seen the data around deprivation in Medway, and it's quite dismal because the uptake of certainly from non-contraceptive perspective is quite low. But we also understand that there are enough, there have been people who've been trained for LARC. So just understanding why that's not being kind of done sort of in a joined up manner. So that's one of the challenge back to the proposal, the person who kind of bid to sort of say, how can you kind of utilize your existing trained resources and how can you bring that together and deliver sort of this wider service? One of the just positives I wanted to kind of raise from that proposal, which I think we hadn't seen from others, were they did mention about the demographics as well and how they were planning to kind of reach out to sort of the hard to reach areas, that, what type of demographics exists within Medway. So I think there are really positives within that proposal. We just want them to strengthen that so that we can give them a green signal to go ahead.
We've got, if you could turn your mic off. Oh, no, sorry, you'll need it multi. No, actually, it's okay. Well, we've got people around the table who can help us with that, I hope, Aparna. So I'm going to take 10 minutes of questions now, prioritising Aparna, okay, because she's got to go. Then we'll have the other presentations, then we'll have the wider questions. So I've got Multi first, Councillor Peake, okay. So if we do with Multi, keep your hands up while I go around. Yep, Multi,
Okay.
if you'd like to ask a...
This is really not a question, just to complement what Aparna has already said. Hubs are part of the bigger strategy and bigger transformation work that the ICB is undertaking. So just really wanted to really share that perspective, because your question around the sustainability is a really important one. And I wanted to just acknowledge that Aparna and colleagues are already working on ensuring that hubs are part of the bigger, wider strategy to improve the outcomes for women in Kent and Medway because of the demographics that we have already seen. So just wanted to assure you that. Thank you.
Thank you, Chair. One of the slides referred to, sorry, I made notes, let me just keep to it, to a sizable portion of the population not willing to seek help or support or to speak about their issues. So I was wondering about the demographics. I was personally surprised by that because my own personal experience working in care, quite often the only man in shift, the most detailed conversations would take, but that was sometimes before 8 o'clock in the morning. But I always felt glad that the women felt so comfortable because I would hear the most intimate descriptions about physical anatomy-related issues, IBS, on their toilet functions, and all these type of things. My mother never spoke to me about things like that, and my grandmother doesn't, but I do with my daughter and my son. And the use of language, at one time I know people wouldn't even use certain words like vagina or penis or whatever. So I thought we'd gone beyond that sort of stigma around using that language and talking about things, because it obviously is so important for people's health to be able to talk openly and seek help. So I was surprised to see this, but I was wondering if there's a demographic around that at all, please. Thank you.
And, because that's part of the Women's Health Network. And we had a very passionate discussion about the role of education, and sort of starting young. So actually there is more to do, but in terms of the actually understanding the demographics, I think perhaps we need to do a bit more deep dive to understand that further.
Hi, Aparna. Thank you for your presentation, and thank you everyone for your presentations. Really exciting opportunity. And I would welcome a conversation outside just to talk about general practice, because as you know, we cover general practice across Kent and Medway. I think that there is definitely a willingness amongst GP colleagues to develop the existing services that we offer. And what I know that myself and my other colleagues want is that continued care of our patients, so that continuity. You mentioned that the challenges in workforce in general practice, which, yes, is definitely part of the challenge, but I think a more significant part of the challenge in this area is actually the training, particularly around LARC. So the training for GPs and specialist nurses to develop the skills to fit intrauterine contraceptive devices and subdermal implants is extensive. And you require supervision to develop those skills, and there is a lack of the supervisors across Kent and Medway. So I've got many colleagues who want to do the training but can't. So I think this is an opportunity to actually invest in a training network, get those trainers embedded across Kent and Medway so that we have a sustainable workforce moving forward into the future, because bearing in mind that this is non-recurrent funding, and that future is questionable. So I think we have a real opportunity here to fix a problem that we know exists. There are also inequities of commissioning across the patch, which I think, again, that's something that needs to be outside, but it's obviously interlinked, but it's funded separately. But I do think that needs to be addressed, because that will enable your workforce to develop in the longer term, and to develop training in all the areas. And I think we also have an opportunity to link with our voluntary sector around the domestic sexual health and sexual abuse space, because we've got an army of social prescribers, we've got these RAs. We need to make sure that they're connected and that we're getting that training across all those health professionals who have contact with women on a daily basis. And also, the third thing I just wanted to say, there's further opportunity potentially in the provider collaborative space of the ICB. So as this current round of NHS transformation is underway, we're talking more and more about breaking down that barrier between secondary care and primary care and bringing those services out to the community. And what the 850 women told you is that they want those services nearer to home. And this could be that opportunity to start bringing those Eurogynae clinics into the community.
Can we just add to that? So one of the slides I didn't show the vision, and actually in the vision kind of like included a range of healthcare professionals with clinical as well as non-clinical, and actually the social prescribers, healthcare champions, coaches, they're all part of that. So absolutely recognise that. And the one thing I forgot to mention is that as part of this funding, what we are exploring is looking at training as a wider area, not just about LARC. So while we've got these proposals of Women's Health Hub, one of the things we're going to be working with our primary care training hub is to look at across Kent and Medway equitably, sort of see how we can provide that training. So I've already had sort of like some conversations with the trainers as well, but how do we train the trainer as well and sort of make that sustainable? But it's not just about LARC. There are a number of different training around safeguarding women's health and safeguarding issues. There are a number of other training, menopause training, for example. So we're going to sort of like, we plan to commission, because we've got a little bit of funding left, we plan to commission training, wider women's health training program as part of this. So, but that's going to be using a phased approach, because mindful that there would be a long waiting list because we've got very limited number of trainers within Kent and Medway, but we're going to explore that, absolutely.
Thank you. Well, thank you for that question, Caroline, because training and development was left out of the initial presentation, and I think it was really important for you to raise it. And what we've heard is that there are lots of people who need the training, and their willingness to get involved is hampered by the lack of training. So that's a very strong message, Aparna, from us taking back to the ICP. Leanne.
Thanks, Chair. Thanks for your presentation. I had a conversation with James about a year ago around women's health, and James started speaking to me about vaccination and screening, contraception, fertility, all of those things. And I said, no, I don't want women's health defined like that. I want it to be broader. We have centuries and centuries of knowledge and skills amongst women. Probably my grandmother and your grandmother had their own way of dealing with these issues. And what I see is a real emphasis on Western medicine and the Western way of dealing with it, which drives us into expensive systems. And I heard you allude several times to, but it's going to depend on the funding. And then what happens, we get into a cycle of the funding stopping. And then we have those who can afford to purchase medical interventions or whatever you like, starting to do that. Then the lower deciles don't get the health they need. And I said to James, I didn't want Medway to be like that. I wanted Medway to be preventative, social prescribing, low cost, no cost solutions to women's health. So I absolutely loved your presentation. I could see where you were coming from, but I think it is going to drive us down a route that is unsustainable. So my plea to you really is, how can we augment that model with other low cost, no costs into communities, into the voluntary sector? Dare I say it, even some Eastern type medicines, acupuncture, massage. I can't get that in this country, but as soon as I leave this country and go home to New Zealand, within an hour, I can get acupuncture, massage, just like that, because the population understands a different model of what we're calling health. And I would love Medway to be like that. We're sitting in a building today that, is so focused on health and looking after yourself and all of those things, that I'm scared, I guess, that model will just keep disempowering us and driving us more into seeking treatment. And James understood that. He got it. And I think fed it back through his team, and here we are today. So just some different ways of looking at it.
Yeah, no, thank you. I think you make a really, really valid point. And I think this is where, when we talked about HRT, for example, in Eastern sort of medicine, there is nothing as HRT. Women have I know, like my mother would have gone through all that phase, through whatever they did. I think there is a balance almost that needs to be struck around evidence-based medicine, which of course has come from, from Western medicine, but that also means that we need to start looking at impact of alternative therapies, as you have highlighted. And I think perhaps nationally and sort of in the wider group, I can take that back to sort of see how we can sort of support that, and how maybe likes of NIHR, etc., can get involved in that sort of space. So I can definitely take that message back. But as I said, is at the moment, I think we're starting at a very at a different baseline. And I think the idea is to get the momentum, and I think it's glad that, I'm really glad that people are talking about women's health now, and I think we've got a long way to go, but absolutely, brilliant point, yeah.
Yeah, because I think that now I've got Councillor Lawrence, Martin and Ailish, okay, before we have the next presentations, but just on what Leanne said, which I do understand and support, this has got to be something women recognise, not something we talk about in a technocratic way, with 10 objectives and a million acronyms. It's got to be something that women recognise, that they can feel, and I think that empowerment is really important. So in promoting the hubs, we need to have that feeling very clearly, if we can, upon it. Councillor Lawrence.
Thank you, Chair. It was an interesting read, even though the paper only arrived quite late yesterday, and some of us were at other meetings, so it was a long night. I just had a few questions. The 850 women who responded to the survey you undertook, how representative of the population was that generally, and how did that message go out that the consultation was actually happening? And then you said you had some engagement events. It'd be interesting to know where those engagement events were. Where are women users in the accountability mechanisms? There's an awful lot of professionals and government and local authority, dare I say, in this, but I don't see users in here at all as a thing. just a bit of a challenge to Teresa on women talking about things like periods. I think younger women do more openly talk about it, and I think we've got to be very careful about planning services based on the past when younger women, my daughter has no fear about talking about these things at all, and nor do her friends. So I think that's really important. There's a lot of emphasis on contraception here. I think we keep talking, most of the conversation has been around LARC, I think it's described that, but obviously women's health is much more than just contraception. So I'd like there to be a more even focus in all areas. I think the other thing is, the other question I had, are the hubs physical locations or are they collection of health assets that can be accessed maybe in different places but through a common entry point? I noticed that there is some reference in these reports to self-referral. Is that a recipe for chaos? Because people will go to the place where the telephone gets answered, and that might not necessarily be the best way of dealing with things. Is there any real scope for innovation in the command and control system that is the NHS? And do you know when you see innovation, and how do you encourage innovation? And finally, Chair, I wonder whether we need to get back to basics, because access to healthcare via GPs is so difficult that if we solve that problem first, then some of these other problems could be solved much easily. You cannot get a GP's appointment, even in Hempstead and Wigmore, and I know it's even worse in places like in Chatham. Getting a GP's appointment is a nightmare. And what I've noticed over the last few years is the fragmentation of services. So my GP is on Beacon Hill, but I've been all over Medway to have different types of consultations.
Okay, I'm going to stop you there, Councillor Lawrence. Thank you for your questions. Aparna, if you could just answer the part about the consultation. The other questions that you've posed, I think we can pick up when we've had the other two presentations. I see you want to come in, Caroline, on the GP. So if you can just answer the bit about the consultations, then we'll pick up those other questions when we come to the general discussion after the other two presentations, otherwise we'll miss them, okay?
Yeah. So the consultation was led by the comms and engagement team within the ICB last year, as I understand, and the questions were kind of like, had included all the clinicians, etc., like, in terms of what would be right questions to ask women and, something that would be not use any NHS terminology. And that was done last year, and it was widely publicised, as my understanding is, by our comms and engagement team. Following that, the focus group was done this year. So we had an evening session earlier in January, if I can recall, where we had a number of, so we had uptake of about 54 women who kind of joined the focus group, and they were they were split into workshops. So these were additional group of people that we wanted to kind of engage with, and they were given the sort of similar questions, and we had pulled out the themes from that survey, from the wider survey, to kind of get women to discuss about that. And so the engagement and the summary that you've seen included both the survey, outcomes from the survey, as well as the focus group. But it was all led by our comms and engagement team.
But in terms of how representative that the answers to those, the people who took part in that survey, is there any data to...
We can share that data, absolutely, yes, because we did sort of the demographics of the population was captured. So so that's definitely available in the report. We can share that.
Thank you. If we can have that as an action for you, Aparna, and we'll publish that with our minutes. And Councillor Lawrence, Aparna did say a physical location wasn't envisaged, it was a collective. And I take the point that you make about the potential for it to be too disparate. So we'll pick that up in a minute. Right, Martin.
Thanks, Chair. I may have missed it, but the 600k from NHSE was for one hub for ICB. So the question is the 600k now divided by 4, but we're expecting the same commitment, or is each hub getting 600k?
So the process that we used was we gave them the criteria, we gave them the challenge, we asked them to come up with whatever that proposal and whatever the costings were. Their costings have come under 600k, and I think that's a positive thing, because if you look at sustainability, they all have thought about sustainability. So we've got the 4 which have come under 600K. So we will be able, and as a result, we'll be able to fund them through a phased approach. But we do have to be mindful that we have got some other areas, for example, when we're looking at training and digital links as well, that would actually enable that whole pathway link.
It was a straightforward question. Is it 150K each then? Or
No, it is not. It's dependent on what their ask has been. So some of them have come under 100K as well, and most of them are around the range of 110.
I suppose then, supplementary question, if Medway's not going to start till September, is it expected to meet 8 criteria by December, or is that timeline laxed because the others obviously starting in July?
So the expectation from all the hubs would be that they would need to be delivering all the 8 core specs by December, whether they start in July or whether they start in September. The September means it just gives them enough time to think about what they haven't included.
And I suppose just echoing some of Leanne's concerns around non-recurrent funding, we all know that obviously you raise expectations, raise capacity, and it drops off. Products, we could look at other way, but a lot of providers are on block contracts. So it's just how sustainable do we think this is going forward in terms of that cliff edge that approaches quite quickly?
Sorry, when you say providers are on block contracts,
Well, I'm just thinking raising the expectations, secondary care, for example, if Jane was here from MFT, she'd be saying actually some of her services will see an increased demand through raising the profile, which is the right thing. But the capacity she has is going to be she won't receive further funding because it's a block. So
Yeah.
it's just those aspects that we're creating demand.
So I think the premise within which we're working is that we actually are trying to deliver services closer to patients' home and away from secondary care. That's the message that's been very strongly communicated, and that may mean that secondary care may need to think about, they may have to think about different pathways where the secondary care consultant comes out in the community or within the primary care setting, or it doesn't have to be a consultant, it could be any other professional group that can provide that services in a primary care or the women's health hub setting. But as I said, that's further down the line, we need to take a couple of small steps to get there.
I think, Martin, we can probably think about as an action a Medway response, because actually I do agree with you. It doesn't seem fair that we'd be expected to be in the same place with a shorter start. And I accept, obviously, upon what you're saying, but the sustainability that Leanne has described needs to be woven into that. So we may need to come back with that and perhaps give a collective response and include, from the board, and include Jane as well. I'm going to go to Ailish, and Morty, I'm going to hold your next response till after we've had the presentation.
Thank you, Councillor. I just wanted to come back on some of the questions and comments that have been asked so far. So I wanted to go back to the Councillor Peake's comments about taboo and stigma, because I don't think we can underplay that enough. I think it is a really significant challenge for women. I absolutely get the point you made, Councillor Lawrence, about a younger generation, but actually our public health team did some research around period poverty a couple of years ago now with young people in schools. And what they found was it wasn't affordability that was the challenge, it was the embarrassment of coming forward to ask for products. And that's only a couple of years ago within our schools. I think if we think about menopause and the conversations that are happening around menopause now, really that's been over the last year, that's in my life experience, it's been over the last year that's been more open. But it's more open when I work in public health within a council organisation. If I worked in a builder's firm, if I worked in wherever it might be, would I feel the same comfortable way to be able to speak to my manager about menopause? Would I feel the same way about approaching professionals about these women's conditions? So I think we're moving in the right direction with it, but I don't think we can underplay the importance of taboo and stigma around these subjects and being able to be open and have those conversations about it. Dr. Rickard, I just wanted to say around the LARC training, I'd be really happy to pick that up with you outside of this meeting, because it's commissioned by us through the KCHFT as part of that contract. So if there's challenges around that, really happy to pick that up with you and try and understand that better. And finally, I just wanted to say, Martin, the public health team are working with the potential Medway provider and are looping in the gynaecology services at MFT as well to try and ensure that is a robust proposal that is coming forward and thinks about the impacts on both sides as well. So we're trying to ensure that that is a fully rounded proposal when it comes back again. So just some assurance around some of those questions.
Ailish. So we're going to go now to the next presentation, which is on community services with Lee Elliott. Aparna, if you have to go, just do so, okay? Because we've still got Malty here to help us. Yeah, thank you. Okay, we're right for ICT for Lee. Yeah. Thank you.
Hello, I'm Leah Elliott. I am the Clinical Services Manager for Integrated Sexual Health at Kent Community Health. And I'm here to kind of talk about how as sexual health we would really like to enhance our service by incorporating some more menopause care and HRT into the service and to help to kind of bridge the gap that is existing. So, KCHFT are a community trust. We were established in April 2011. We're one of England's largest NHS community trusts. We have 70 services, community nursing, health visiting, school health, and us. So our ISH service provides a comprehensive range of services to support and deliver sexual health within the community. So we offer contraception, LARC, coil, and STI fitting, pills, patches. We work with the local pharmacies who also provide contraception. So they provide EHC for us and treatments, and they are now offering contraception on a walk-in basis to a lot of women without an appointment. We also offer services around psychosexual health, which means that we also deal with those relationship issues during menopause. There can be lots of issues that come up around relationships and people not kind of feeling kind of wanted or partners kind of disengaging. We also provide HIV services, so we do the treatment and the care for HIV and incorporate their care. We also do prisons and hospital care. So our proposal is we would really like to enhance our service by including some HRT. So currently, as we've heard, there is a significant gap in the availability and accessibility of HRT for menopausal women. This expansion would allow us to provide better access to menopause treatment and address some of the unmet need that there is, aligning with the women's health strategy. Our aim is to offer a holistic approach to women's health, encompassing both preventative care and treatment options by integrating some HRT into our service so we can empower women. Sorry, next slide. So, menopause, women face unique health needs and often are underserved by our current healthcare system. Accessing hormonal HRT can be challenging. Many women will seek barriers in getting GP's appointments, GPs kind of not having, like Dr. Richards was saying, not having time to do the training or the significant training, and alternatively having to go private, which bears a cost. Some of the symptoms can be hot flushes, mood swings, vaginal dryness, anxiety, that women have never experienced. So there are lots of things that we can help with our psychosexual services as well as within our clinics that we can help to support these women. So despite the importance of menopause, there are several gaps in public health of offering HRT. As you can see, GPs are already overworked. They are expected to kind of know lots about everything, and unless they have got some of the specialised nurses or doctors who take an interest, sometimes that there can be a gap. Like we've heard, there is an issue with training, and in order for them to do that, they need to find trainers, there needs to be supervision, so that can all lead to gaps. Women that are going to private healthcare, it obviously is a cost. If you can afford that, then that's fine, but lots of women, especially in Medway, they can't. They're not able to access it. Next slide, please. So, as we've said, there is a fragmented system, which means that some people will go and their GPs will be really engaged and they'll get kind of services. Other women will say, we've done a blood test, everything's fine, you don't kind of need that provision. Training and resources, again, there needs to be kind of more funds put into that so that we can support the GPs, practice nurses and communities in order to be able to do that. Workflow, patients going back and forward. We are a completely standalone service and we are anonymous. So your patients may be seeing us, but we aren't going to tell you that they're seeing us and we're not going to feed that information back and we can't access your records to see that they have gone to see you. We have lots of women that are coming to us for LARC, for contraception. And a Mirena coil is now licensed for 8 years for contraception, but 5 years for HRT. So we have lots of women that come back at that 5-year mark wanting it changed, and because of the way we are commissioned, we aren't able to do that change because contraceptively they're still covered. So there's a lot of us referring backwards and forwards to GPs. And again, lack of information out there for patients as to where they can go to get the help and support that they need, who they can talk to and how they can access services. Next slide, please. So our objective is to kind of hopefully reduce some of those inequalities by making it more accessible. So the women that we're already seeing, we're already fitting coils to, we're already dealing with their contraception. It just kind of seems like the next step would be for us also to deal with some of their HRT issues and to deal with some of the kind of psychological issues that they are experiencing with relationships and things. So we would hope that would release some of the burden from some of the GPs if we were able to provide that. We already have the LARC Fitters programme, as has been discussed, so we are commissioned by Medway Council. So we train GPs in LARC fitting both coils and implants. We train them around specialist contraception and they can refer into us for specialist contraception. If there are issues, I'm happy to kind of pick that up with Dr. Richards if she feels that there is anybody that, you know, we can help and support. Absolutely, we can do that. And we have 2 SRH consultants who work with us in the community, one in East Kent and one in Medway. So we would really like to progress, train them up to become faculty registered menopause care practitioner trainers. Therefore, they could help with some of the training with the GPs and the practice nurses in the local community. We already have those networks. We have 7 GP surgeries that already will pick up and do core fittings for other GP surgeries. So we can already draw on those networks that we've already got, implement some training quite quickly in order to be able to kind of get some of that support in. Next slide, please. Okay, so again, women's health, as we've said, is a really important topic. There, you know, I think it needs a multifaceted approach. Women's health hubs are great, but often, if they're in a central place, women have to travel. Women want to be able to access that care there and then with the person that they're with. So if they're in sexual health and they've gone to the GP for vaginal dryness and the GP hasn't examined or said that it's thrush, and I'm not bad-mouthing GPs at all, they do a fantastic job, but they will then sort of come into us and we will examine and actually say, vaginal atrophy, you may need a little bit of estrogen gel, this is what could happen, but we're not commissioned to provide it, so that woman then has to go back into primary care. So if we were able to offer more to the clients that we are already seeing, hopefully that would alleviate some of the burden and hope to close this gap. Thinking about the points that you are looking for in hubs, we offer contraception, we offer LARC, we offer cervical screening, we do HPV vaccinations and we do HIV care. So we're already in a really good position to tick a lot of those boxes for those hubs. So that's it. Thank you for listening.
Thank you very much, Lee. And I think we've heard there, haven't we, that there are some communication problems. And one of the worst things for somebody who has come forward with a problem like vaginal dryness is to find that the source of help was the one they went to in the first place and they're now being referred back to them. So we do, and Caroline, absolutely, I will give you an opportunity first after the next presentation to respond to some of the things that Councillor Lawrence said and now some of the things that Lee has said as well. And, you know, I think it is important to recognise that we've got to give GPs, through their own organisation, the local medical committee, a voice. That is their professional organisation, their trade union, if you like. And, you know, we don't want you to feel that you're here on the defensive, but absolutely I recognise your right to come back on some of those things. And for Malti, you know, some of that commissioning, I think that we've heard some avoidable problems there, haven't we? Okay, going to go to the next presentation.
Hi, thank you everyone for inviting me. So I feel like I'm coming from a very different standpoint because I'm the clinician on the ground. So I'm an advanced nurse practitioner in primary care and I do champion them. And a general nurse practitioner at that. So I'm going to pass it on to the next slide, please. Thanks. I'm just going to quickly run through about me so you know where I've come from. So although I qualified in 89, long time ago now, did a long time in A&E, then moved into primary care, trained as a nurse practitioner, trained as a prescriber, and then developed a very strong interest in women's health because I was working with male GPs, so I naturally got to see a lot of the female conditions. I learnt how to fit coils, I learnt how to do implants, I learnt how to do contraception, a whole range of women's health, did a women's health diploma. But it wasn't until my own personal experience kind of kicked in. And to be at the time that I was in general practice in the early 2000s, there wasn't a lot of menopause care, good menopause care going on, because there was a lot of fear in the media about studies that have been suggesting there was increased risk of breast cancer, there was suggested increased risk of heart attacks and strokes, for example, and there wasn't some really good HRT available, so there wasn't a lot going on, and certainly not a lot of training for GPs and clinicians like me. I was lucky I did a women's health diploma, but even then when I look back, it wasn't brilliant. So I didn't see my own menopause approaching, and being a women's health nurse, I was disgusted that I didn't pick it up, but I didn't. I had a Mirena coil, didn't see my period, so I wasn't aware that all the menopause symptoms I was getting, and they weren't classical, were actually my menopause approaching. And it got to the point where I nearly left my job, and this is the value of education to everyone, because people will be losing their jobs or because they can't cope with their job anymore. I had a lot of anxiety, palpitations, migraines. I wasn't sleeping, putting it down to the stress of the NHS. And actually, if I'd have had the education again, a bit more as a clinician, I might have joined the dots a bit earlier, but I didn't. So when I did, I'd gone to a wonderful training, and this was in 2015 when the new NICE guidance came out, and it really refreshed knowledge. So I went to a wonderful study morning put on by nurses, 4 nurses rather, about menopause care, and I sat there and it's like the light bulb went on, and I thought, oh my God, I'm working in general practice. One, I didn't see it coming for myself, and then I looked at all my patients and thought, how many people are we missing? They've come in with their aches and pains, their migraines, their anxiety, they're not sleeping, depression, all sorts of symptoms, and we're not picking it up because they've only got 10 minutes. They've only got a little bit of time to say what their main problem is. So that made me very passionate once I got the help that I needed for myself, and then I thought, no, I'm going to train as a menopause specialist because there's much needed care out there. So I set my path to train as a specialist, and I did the faculty at the FSRH special skills, got that training, and then the advanced menopause certificate, and I'm now a British Menopause Society accredited specialist, which was a process of training. But then I in my job, and I'll go on to my job next, but in my job, I also felt like that there was more people wanting help, so I set up as myself as What's in Health and did some advice and guidance on the side, and also some education work, corporate training and so on. And then I also realised the importance of mental health and cognitive behavioural therapy, and just didn't feel that it was available for people. There was the mental health services and counselling and CBT available for people, but maybe not specifically for menopause, and that was what was being advised in the NICE guidance. So I trained to deliver that as well. Next slide, please. So the current situation, I work for Medway Practices Alliance, and they're we run a group of surgeries, basically. So I work primarily at Balmoral Gardens, and as a clinician on the ground, I have specifically now reduced my work to women's health. So I think we're championing women's health clinics. All my clinics are women's health appointments. So I can do coil fittings, implants, ring pessaries, fertility assessments, gynae exams, genital problems, all sorts, breast. So I kind of I'm like my own mini little clinic. and I think we're really championing this women's health model, but it's just me. We get paid for the larks, we get paid for the coil fittings, and I also do the IUS fittings for menorrhagia, so for heavy menstrual bleeding, which you don't get funding for, ring pessaries and so on. So we do get some income generation. But menopause care doesn't really attract any money. So I'm really doing is, Medway Practices Alliance are allowing me, and I put my foot down, I want half an hour for each of my ladies, because they can be quite complex. Menopause care is not just a procedure. It actually involves clinical assessment and choices, holistic care. I'm not just shoving pills at people. I want them to know the whole scope of treatments that are available. And I'm going to go on to the benefits of a menopause consultation shortly. But, the long and short of it, it's not funded. I'm not really supported in my role. I'm on my own. So I've got no one to go to, apart from, obviously, my own network outside of my job. I go to my trainer and I go to my networks and forums that I've created when I have a complex case that I need to discuss. I can't go to my own team because they come to me. So, and there's no collaboration. So we're not collaborating with the Medway. I might have to pick up an advice and guidance call and speak to someone, but actually I get a gynaecologist who doesn't necessarily know menopause. You can't necessarily jump onto a call with a menopause specialist. It's not as easy. And then it's not sustainable. In March, I went off for ankle surgery. I ruptured a tendon, and it took me out. I've only just gone back to work this week. So actually, then, nobody was getting the care because there wasn't anybody to replace me. Now, we are, in MPA, we are training up Raquel. She's a practice nurse who's interested in fitting coils, and she, I can't train her because I'm not a faculty trainer, although I could get onto that path. This is obviously the wider training, the next level. So I could train to become a trainer and then train other people. And similarly, being an advanced menopause specialist, I can also become a trainer for that. But again, it's getting onto the path and then being supported to do so. So I can't really do this on my own. I'm the clinician, I don't make the decisions. Next slide, please. So the value of menopause care is not just about symptoms, and briefly speaking, vasomotor symptoms, the hot flushes and sweats are only part of this. You've got physical symptoms, head to toe, inside and out, and there's so many and varied. You have, for example, migraines, headaches, itchy skin, dry eyes, palpitations, brain fog, poor sleep. There's loads, symptoms. Then you have mental health symptoms, so anxiety, loss of confidence, depression, mood swings, anger, relationship issues because of it. You also have genitourinary symptoms, very specific. You mentioned vaginal atrophy. They've gone to their doctor or thinking that it might be thrush, but actually when you examine them, it's not. It's lack of estrogen. So there can be genitourinary symptoms. And then you have all the mess with periods. Periods can be a right old problem when they're going. So it's like teenage in reverse. They become all over the place. They can become heavy. They can become painful. Then they need, looking at sometimes examining, sometimes scanning, and so on. But it's not just about the symptoms. When somebody comes to you, this is an opportunity to do an MOT to look at their health, really what are they doing with their lifestyle? Are they smoking? Are they drinking too much? What's their weight like? What's their blood pressure like? Because you're looking at all these things. I see it as a golden opportunity. That's why I put my foot down and said half an hour, because you need that time to really go through these things. You know, look at how they manage their stress. And then, you know, you are then preventing chronic disease for the rest of their lives. You know, we've already mentioned that women are living longer than men. They live on average about 83 years of age, whereas men are dying younger, 79. But women are living proportionally longer into their older years with disability and diseases that could have been prevented with good care. So it's so important. This is, you know, these health checks are perfect for this. And mental health, really important. Quite often we see, and so many women have said, they've gone to their doctor with their one problem that they're allowed to talk about, which is anxiety or low mood, not sleep, and they get put on antidepressants. It's not the right treatment if it's a hormonally related issue, or not necessarily. So you have to look at the wider impact of that. And this is where the CBT can really play a part. And then you've also got the value of it, keeping people in the workplace, really important, because actually I could have left. All that talent, all those things that I'd learnt over the years, I could have just given up and not worked again. And they'd have lost someone with my years of experience. And yet I came back and then got better. You know, you can really thrive after the menopause. So you can retain your staff as well. So it has much wider implications. Next slide, please. So our current barriers for patients, yeah, you mentioned it already, it's difficult to get an appointment, totally get that. We are very, very busy, 100% very, very busy, I can't deny that. And there, you know, ever since the pandemic, things have changed. We do a lot of electronic consultations, a lot of triage is actually done. We use an anima system, which has its benefits, it has its problems. People don't always like it, but it's the way we're managing things in the practice at the moment. And it can be really difficult to get an appointment, and people have got to know what the issue is as well, you know, because you go into these electronic things and it says, well, what's the problem? And, you know, they might say, well, anxiety, and of course it goes down the anxiety path. So you've got to be really careful with these systems. If a woman knows that they think it's menopause, it's a little bit easier, but they don't always know. They don't actually recognise their symptoms like me. So, and also, it's not like they have a raging sore throat and they need antibiotics or something, or you know, something that's urgent. They might not bother. They just think, well, this just... they don't feel it's so much of an issue to really try and get an appointment, so they give up. Then we've already mentioned about clinician skill. This is all about training, education. It traditionally hasn't been there for GPs and clinicians. Now there's much more out there, and it is getting better. It really is getting better. So I want you to feel positive. I've been involved in some training with I'm not going to talk about other organisations, but it is getting better for clinicians. But having your symptoms recognised is so important, so people know. So clinicians are joining the dots when they see someone come in with various symptoms. They also want to have a continuity of care. They want to come back to the same person and see the same face, and it can be quite difficult to arrange that. We've already talked about Myrina Fits for HRT. Difficult because you're not funded for that. So I can do that, but we don't get paid. Well, yeah, we do get paid. It's a bit convoluted, but yeah, so Myrina Fits for HRT can be a problem. It's all right if you are in a practice with a fitter like me, but many practices don't. Then you've got specialist cases like surgical and premature menopause are not being picked up very well or not treated very well. You have language and diversity. In Balmoral, we have a good proportion of people that don't speak English as their first language, so we use a lot of translators. They need extra time, and they find it hard to use the anima system. They find it hard to access. You have diversity, different gender expressions. You've got people with neurodiversity. There's all sorts of people that you have to consider. And then you've got the waiting time to see a specialist, can be ages. Next slide. And then I've got to talk about the social media. Obviously, there's been an absolute menopause revolution, and it really, with the likes of Davina, social media, there is a lot of information and misinformation going on. So there's a lot of GP bashing. I'll just talk about a forum that I keep an eye on. It's a menopause and HRT discussion group. It's a Facebook group, and I just quietly keep an eye on it. It's got many, many followers. But they are forever moaning and groaning about their GP, not understanding, not getting time, and they're getting misinformation, and they're advising each other, and it make your hair stand on end with some of the comments that come, and I have to hold back because I don't want to get involved clinically. But there is a lot of misinformation out there, and there's a lot of mistrust of clinicians at the moment. They don't trust their GPs, and I find that really worrying. And there's also a lot of mismanagement going on. So the public have got big expectations, and they're coming forward expecting their GP to know absolutely everything, and some very complex things, and they can't simply know about everything. They just can't. So next slide. This was something that this is my own personal kind of view on things, and this isn't anything in the national strategy, or it probably is in a certain way, but I just see the majority of menopause care should be in primary care, should be in your GP surgery. We should be able to handle 95% of our menopause clients, because for most women it's a natural transition, and it should be able to be managed. And we should reserve our more complex cases for the hubs, perhaps for enhanced care, for those complex or perceived complex patients, maybe that they've had thrombosis and the GP's worried about giving HRT, or they're having multiple treatment failures, or something along those lines. But maybe more complex cases, but not necessarily having to go to secondary care. There's not many patients actually really should have to go to a secondary care level specialist. Next slide. So we've already talked a little bit about the Women's Health Hub model. It's been bandied around today, and it's not new. So it does bring together a range of women's health services, so that we've already spoken about those. And the Primary Care Women's Health Forum, the reference that I've put down the bottom, they talked about this a couple of years ago, how it was a toolkit of how people could set this up. Next slide. So you already know about the guidance that's in place. So I've put the references at the end if anyone doesn't know the guidance. But these are the kind of the core specifications. I looked into it a little bit before I came. And then the cost-benefit analysis, which is way above my head because I don't get involved in the strategic kind of stuff that goes on with money. But it definitely seems the way to go. And I think it doesn't have to be all in one place. As long as we are all working collaboratively, I think the system needs to work collaboratively. And somebody mentioned a hub and spoke model, and I don't know if that's a specific. To me, it sounds like I could be a spoke, but I need someone to support me as well. So it'd be nice to be part of a collaborative working system, because I'm already doing much of that kind of thing. But it's a way of bringing all the services together locally, where women need it, and not having to go into hospital. Next slide, I think, is my thank you. So sorry if I went on a little bit, but...
We invited you because we wanted to hear what you've got to say, and I think that was very comprehensive and very helpful. Now, we're scheduled to finish at 4, but I don't think we're going to. So I'm going to extend the meeting a bit so that we can have questions. I think there'll be some follow-up for us to do, and we'll come back to those people who want us to follow up. But for you, Lisa, thank you very much, because I think you highlighted, you know, what it's like, and the same for you, Lee. You know, we can see where those glaring omissions and duplications and avoidable situations are for women. And for me, the ability for someone to go and have a half an hour consultation with a friendly face is absolutely, you know, highly desirable. And you're describing a model that we talk about a lot but don't deliver, and that is, you know, a GP service where there are different practitioners dealing with different things who can be accessed quickly. And we know that we're not where we need to be on that. So thank you. Now I'm going to go back to Caroline, because you had a couple of sort of challenges from Councillor Lawrence there. So I think it's only fair for you to be able to pick those up for us first. And Lee, similarly, you told us about these sort of ping pong that are not very desirable. Then I'll come to you, Malty, because I know that you wanted to add something, then everybody. Okay? So Caroline Furr.
Thank you so much, and thank you, Lisa. So I think I just was going to pick up about the training that I was referring to. It was actually specifically about the LARC training, but it is across the whole of health hubs. And I think some of these anecdotal anecdotes about experiences, while they are you know, absolutely true and valid, they don't represent the care that many of my colleagues are actually giving to women and want to give to women in general practice. And I think, Lisa, that kind of speaks to what you said. I really enjoy supporting my female patients through this natural transition in their life, and through every transition in their life. You know, we haven't spoken about birth trauma, or about all sorts of other complex areas of women's health. And what I value most about general practice is that continuity of care. And so I do want to make sure that women's hubs don't fragment that care, but build on, as you say, as a layer that we can use so that women can have access, and that we can also utilise to have access to that specialist support that we need. General practitioners, by their very nature, are generalists. So we've all come into general practice with different skill sets. We've all done different specialties through our basic training, and then we do through the Royal College of General Practitioners the generalist training to make sure that we've got that generalist overview. And so within every practice, generally, there is you know within your practice which GP has their special interest in cardiovascular disease, who's got their special interest in frailty, who's got a special interest in paediatrics, and who's a women's health kind of specialist. And generally within a practice, it kind of you know, that's how it evolves. And how we make sure that everybody has a good base offer where we see that there's gaps, where we need to uplift that offer, is through local enhanced services. So that is where funding is put into general practice to upskill and deliver specific services to patients. And I think that's what you're talking about, Lisa, which I would absolutely support that idea. I think access is a challenge. I hear you, and it is a challenge, and there is a reason it's a challenge. Since 2018, we have lost 51 GP contracts across Kent and Medway. 51. We currently in Medway and Swale have one full-time equivalent GP to 3,833 patients. Despite that, in April 2024, we saw 950,000 patients across Kent and Medway. So there's a population of 2 million in Kent and Medway. So 1 in 2 people in Kent and Medway are going through their GP practice and having an appointment every month. So the issue we have is that we have a capacity issue because we don't have enough general practitioners. And that is a result of chronic underfunding at a government level. So I think, yeah, I absolutely hear the frustration, and I really kind of would applaud everyone in this room to put pressure wherever they can on the government to improve the funding for general practice to make general practice a better place for everybody, for the people who work in it, for the people who access it, for absolutely everybody. Thank you so much for giving me the time to speak.
Thank you for your frankness, Caroline. It's important that we hear you, and the loss of 51 contracts is felt right across the ICB area. So Malty, please. And
Thank you. Thank you, Lee, for sharing your things, your knowledge with us, and particular thanks to you because you shared your personal story.
Yeah.
And I think personal stories are really powerful stories, and women, many women, I think, in this room probably relating to what you were talking about. So the point that I wanted to make was, I think some of you know that I'm a consultant in public health by background. What was really stood out for me was, or what I have heard, in my opinion, is having the whole pathway approach to improve access, experience and outcomes for our women in Medway and Swell. That's what I have heard. I also want to acknowledge what I've heard about getting the basics right and getting the training. At universal level training is important, but also the enhanced level training. So I've heard that. And I've also heard about the harmonization of some incentive schemes across the differential in the local authority for for the contraceptive purposes, and the less enhanced scheme in the from the ICB for non-contraceptive purposes and the gynecological aspects. What I am proposing is, as a way forward, is to have an offline bespoke conversation with relevant colleagues to join these pathways up. So the things, Lee, that you highlighted, articulated, the aspects that Martin, you articulated in terms of starting in September, what would that mean for the deliverables by December, and the aspects that Eilish, you pointed out in terms of the training, etc. So if, as an action way forward, if that's acceptable, I would then take it back to Aparna, and then we from the ICB would have a bespoke conversation to see how we join it all up, to look into how we improve the bits around access, experience and outcomes.
that's very helpful. And we'll talk together about how we achieve that. Thank you. Martin.
Thanks, Chair. Thank you for the presentations. I suppose, Leah, the first question really was, with the restrictions on, or the opportunities you have in expansion, are the restrictions purely contracting and financing, or is it practice? So if you had more money, would you be able to do more? And then the second question really was for Malty, but she's just answered it. It was around, do we have an opportunity to expand the bid and include MPA, KCHFT as part of the bid and for the hub? So we have a hub and spoke model, which I think you're saying we take it away. And
so particularly around hub, Martin, I don't think I am able to comment on that because Aparna has been very close to that process rather than me in that. But what I am definitely offering is, let's have an offline conversation to explore different options, that how do we bring some of this work together, whether it then turns out to be hub and spoke, whether it turns out to be bespoke training. It's too early for me to say that without exploring it with the right colleagues, but what I really am keen to do is have that offline bespoke meeting to consider the issues that have been highlighted today.
And we'll facilitate that as soon as we can, based on what you've said about the Medway proposal and so on.
Thank you.
Yes, so if we had more funding, then we could obviously then provide those core changes at the 5 years for women. We would be able to issue the vaginal gels when we see them. We've already got the building. We have 4 Clover Street, which is set up, ready for us to use. We've got the staff that are trained with the coil fitters. We've got the SRH consultants. It's just, obviously, we have an envelope of funds, so therefore there has to be a cut-off of what we can use them for, and we have to then go back to Medway Council and kind of say this is what we've done. We do have a lot of conversations with women at that time about the need for HRT and contraception and if they weren't with their current partner, or, you know, we word it in ways that we will kind of try to do it if we can. If we can make it happen for them, we will, because we do not want to send them away, but it is definitely a funding barrier.
You need to be part of that conversation, Lee.
Yeah, thanks very much, Chair. I've found these presentations very interesting, particularly with regard to what I've learned today about GP surgeries and hubs and their role. I was just wondering, from the point of view of education generally, and going back in a way to the Director's comments about low-cost achievements that could be made, what should we be doing, or put it another way, what are we already doing, perhaps, that I don't know about, to get the education message out in various other environments? I was thinking of supermarkets and that sort of area, where, of course, you've not only got members of the public, customers visiting, you've got employees. And we go back also to Councillor Peake's observations about breaking down the barriers. So I was wondering what sort of public health work on a lot of this stuff. Wouldn't want to, menopause is one thing, but there's a lot of other very useful information we've had here this afternoon, and a lot of other health themes affecting women. To what extent can we take the message out in libraries, supermarkets, etc., and to what extent are we already doing that?
I'm going to ask the public health team perhaps to respond, but do it when I've taken the other questions, Mark. Thank you.
Thank you, Chair, and thank you, Lisa, for your presentation. It was really interesting. And I just wanted to sort of touch on your point about your personal experience in menopause and sort of the workplace, and sort of Multi, your point there about sort of bringing personal experiences into this conversation. And through Healthwatch Medway, we do get feedback from women, especially around women's health. And I just wanted to bring one particular piece of feedback into the room, and that was a woman who was really struggling with her menopause symptoms, and especially struggling with work. And I don't have the case study in front of me here right now, but as I remember, if I'm remembering correctly, her employer didn't want to put the necessary sort of changes into place to accommodate her, and the situation actually ended in her being fired from her job. And I think it really sort of puts into perspective that the real lack of awareness that there is, especially sort of in workplaces, and sort of the lack of knowledge there, how to support women as well, especially through sort of menopause and wider women's health experiences. Thank you.
Thank you. And I think, the point was made, wasn't there, that it's all very well for Davina McCall, who's in a position of strength and power, to put these things forward. It's different for other people, and I think we have got some work to do through our workforce arm of public health to promote menopause-friendly workplaces, absolutely. Eddie.
Thank you. I'm typing away. I want to reference three people here, so sorry about this, bear with me. Caroline mentioned about the lack of funding. I mean, this is self-evident. Anybody who denies this is in another planet. There is that old adage about you get what you pay for, and certain politicians seem to only apply that to certain things when really it applies to everything. However, I don't think that is the whole story. I do think there is also the elements, from what I've read, I'm no expert, that there's a lot of GPs who do not actually want to run a business. There's a lot of grief. I used to run a business. I have some idea about the amount of work you have to do just in the function of running that business, rather than the actual service that you're trying to provide. So I do think there is a case of how GPs are funded. It's definitely something that needs to be a discussion between politicians and GPs. That's what I wanted to say on that. I wanted to say, make sure I've got the right person, could be typing away, to Lisa. Really galvanised by what you said, your journey. Wow. I want to applaud you, but I don't know if that's appropriate or not. And I can really appreciate how you identified a specific need and then decided to do something about it. Yes, thumbs up. So I just wanted to say that. But this thing about being trained and specialised also taps into what Leah said. I will get to the question eventually about the lack of consistency when you go to see a GP. They are, after all, only human beings, and they have to know a broad range of things. Identifying, being able to feel comfortable to speak up and identifying at early stage is so important. I'm quite angry about what I've read about men, because men quite often, in fact, I know somebody and his wife used to moan her head off. He would not go to the GP. By the time he sought help, not only has he damaged his own health, he's now costing actually the health service a lot more money because it's much more expensive to fix him. I've never had that problem, as people know me. So 3 years ago, I have an operation on a very intimate part of my anatomy. The point about this comment was that when I went to Medway Hospital and I saw a GP, it wasn't the fact that she was a GP. What I really appreciated was that she clearly was specialised in this particular subject, and that made such a difference. I instantly felt so relaxed in talking to her about the most intimate details you could possibly do, no problem. So that specialised training is obviously very important, which leads to my question to Leah about training. What is the availability? Because obviously costs about training GPs in more specialised areas. Is there a budget for this, or is it totally inadequate? Please.
So I'm not sure about GP funding and how that's allocated for training, because I work for Kent Community, so we do provide LARC training to GPs, but with regards to training, there is training available from the Faculty of Sexual and Reproductive Health. Obviously, Lisa over there can do some training. There's online courses, but I'm not sure whether GPs, how they work their budgets with regard to training and how that's allocated.
Is there somebody else that can help with answering that? Could it be?
Well, I think, Eddie, I mean, it's an important question and important comments. We've said that with Malty from the ITB, we'll have an offline conversation and facilitate that. And it does occur to me, we might do well to perhaps have that at Clover Street and bring people together, because it would make sense for some of us to be able to do that. And TAS, Health Watch can help us here. Particularly with some of the elements you raised, Councillor Lawrence, about engagement. Who is actually being engaged? What are they saying? Is that group diverse enough? So perhaps we can include you in that conversation and have a talk about that, because you and I, Tass, have talked about before Health Watch getting involved in things that relate to the things that we want to achieve, as opposed to things that you're sort of trying to respond to. And I think that would be helpful. And what I'm proposing, Jane, I'll take your question, and then I'll ask public health feedback quickly, as I'd asked, and then I'm going to make a proposal of dealing, I'm going to make a proposal first with dealing with this. Okay, Jane.
It's more an observation, I think, Chair, rather than a question. It's to do with the lack of consultation, I think, really, in terms of this whole strategy going forward for Kent and Medway with voluntary sector. We've got 3 organisations here who represent women who are experiencing the greatest barriers to access to the voluntary sector because of their own particular situations or because of their cultural values. And I'm not aware of any consultation that's actually gone on with the voluntary sector groups that are on the ground working with these groups of individuals, these groups of women, number 1. Number 2, if we're going to do an education piece, and I think that's really, really useful to do that, because I think there is a lot of, I agree with you, Ailish, there's a lot of stigma, there's a lot of anxiety from women, there's a lot of fear. But most of all, I think, I'm going to be speaking probably out of turn when I say this, thinking of your example of a construction environment, the people who make it not okay for women to have menopause are men who don't understand it. And I think that education piece actually equally needs to be directed at groups of men as well as women. And I might be speaking out of turn, Chair, when I say that. No, from my own personal experience, as well as yours, I can understand that you've got some of that as well. I think that's probably a major issue.
No, and I'm afraid it's not just men in the workplace generally. Men in GP surgeries are not very helpful towards women. And when we had a big event at Lordswood Leisure Centre towards the end of last year, one of the things that people said, and in fact the menopause consultant from the hospital said, she's sick and tired of women having to go into combat to get noticed, even to get a blood test. actually, that will, so you know, you will have heard this story before, Lisa. We've got to do better. And collectively, we've got to get our voice going. So I'm going to ask Ailish from the team, just responding to the communication part of it. I will come to you, Councillor Lawrence, and Eddie will see if, and I'll come to Rupa, and then make a proposal, because I'm conscious of time, and we've got another item, which is the work programme coming up. So, Ailish, please.
Thank you. So there is a lot of work that public health does around communication and trying to address stigma. So the work I talked about earlier in terms of schools, we've got a comprehensive PSHE programme across schools now on the back of that research that we did around period poverty and what became more evident period stigma. We are now have embedded that within our PSHE lessons for boys and girls to understand menstrual cycles, periods, and on through menopause. Although I'll be honest with you, I don't think a 15-year-old's thinking when she's 50 and what she's going to be going through, but we're embedding it right at that early stage. We have expanded our workplace health programme to include menopause now as well, and there is training available through that workplace health programme for all businesses. And our workplace health programme works with around 300 businesses across Medway, and we target routine and manual employers, as well as doing work with small and medium enterprises as well. So not just working with our very large organisations, although they're really important as well. But I guess there's also a challenge for, if I'm allowed, for us as a council, because we own those libraries, we own the leisure centres, we own a lot of those spaces. So what are we doing corporately as a communication? You know, it doesn't just need to come from public health, but what are we doing as a corporate organisation to try and raise awareness around that as well, and where are those discussions being had to see where we can improve our communication to our residents as an organisation to be able to improve those messages around that as well.
Thank you very much, and absolutely, you know, I'm going to keep saying this, you'll keep hearing me, the prevention agenda has got to run right through the council. It's got to be in every place that we are, because otherwise it is meaningless. We're only talking about it to ourselves. Rupa, please.
For bringing that up. And also Councillor Lawrence very rightly questioned about the 850 people who were consulted. And I think listening to all your lovely presentations and the professionals here, the message we are getting here is, I heard around, is social prescribing, bridging the gap between the primary and the secondary care, complementary therapies, alternative medicine, prevention, a big thing with public health. And with all this, I think it is very important for us to recognize and celebrate what the voluntary sector is doing to actually minimize the burden on the National Health Service. And Jane, rightly so, being, you know, the leader of the voluntary sector, she really does bring all of us together in working towards prevention. And I think it is very important for this group to recognize the contribution that the voluntary sector makes. Very briefly, Chair, if I may, I had consulted some community leaders before coming to this meeting. And something they asked me to communicate to the meeting today was obviously ensuring women's voices are heard in every sphere of the support, tackling taboos and stigma, like you know, you mentioned here, in terms of pressures on women's lifestyle and well-being and expectations of culture and religion, on the choices that these women make. It's very important to understand that. Ensuring that women are listened to by the healthcare professionals and increasing representation of women at all levels. They need to be involved in the decision-making process as well. Another thing, this is a bit clinical for me. Someone said perimenopause is not discussed enough, as well as menopause and infertility.
So PCOS can impact some Asians, and there are too many old wives' tales out there that could be countered. Yeah? Awareness of premenstrual syndrome, menopause, postnatal depression. It's inadequate, generally more so in BME communities. Psychosexual health services need to be improved in the community and to be more user-friendly. Okay? And also, I got the message from someone that mental health professionals need to be more involved in the psychosexual clinics as well. Good nutritional advice around menopause would be great. Yeah, these are some of the messages I got, and I hope it will help all of you to kind of work with all of us in this sector to, minimize and address these issues.
Thank you very much. To help. Thank you very much for asking those questions and for sharing them with us, Rupert. That's really helpful. Councillor Lawrence, just quickly, your last comment, please, before I come to my proposal.
Chair, when you cut me off in full stream before, one of the issues I raised was accountability. Who's the leadership on this? I think it's the ICB, but maybe it's the ICS really is the leadership. But also making sure women are part of the decision-making process, users of services. I think that's absolutely vital, otherwise it's being done to them. A call out for early menopause, but also for the screening of women who've gone into early menopause, because it's been shown to be hereditary, and it could stop fertility issues later on if certain decisions made at a given time. And I think the other thing from all the presentations, albeit Ailish has touched on it, is education. So actually, I think we need to make people accountable for their own health, number one, in a wider healthcare place, and that requires education, and it also means that women need to know when they can expect screening at certain points in their life so they can go forward and ask for it. Because I think a lot of women wait at home for the letter to drop on the doormat or to get the text saying it's time for this screening or that screening. So all of those things I think need to be built into this healthcare strategy.
Thank you, absolutely. Morty, do you want to just say something quickly about accountability?
So it is ICS, shared responsibility, which is why I think taking a pathway approach is important, because when we take pathway approach, we can be really clear about what bits, who is responsible for what. So, for example, the sexual health services and contraceptive is responsibility of public health and local authority, and we've heard about the GP side of things is responsibility of the ICB. So that's one example. I could go into several examples. Similarly, screening is shared responsibility, vaccination is shared responsibility. So there are things, and that's why I'm proposing that we need to be taking pathway approach. Thank you.
Which I think you're absolutely right there, Councillor Lawrence, which is all fine as long as that shared responsibility doesn't turn into a sort of ping-pong between who actually is going to be there at the point of delivery. And we've heard today that that's
Sorry, I didn't know if you was going to allow me. Definitely there's a case, I understand where Jane said what you said, definitely a case that a lot of men don't understand things like menopause. What's alarming is they quite often don't want to know, and therefore they do need to be challenged, and all gender-related things need to be constantly challenged, otherwise it'll just disappear. But I will just want to say this because I think it is important. As a trade union rep, I had a real-life case where a female fellow colleague claiming to be speaking on behalf of all the rest of the female colleagues in our office was complaining about our manager who did not want to know about menopause, ministerial issues, all those things, but that our manager was a woman, and she was totally reactionary, and she was very much the pull your socks up, stop making a fuss brigade, and she was actually impossible to talk to. She just didn't want to know. So
we're only very nearly perfect as a group. That's the situation there. So what I'm proposing is that Steph and I look at all the things that we've raised today. They're all important, and I think, I hope people around the table will agree this is a really good discussion, because we've looked at the high level, we've looked at the funding, we've looked at, where the professional crossovers and barriers are, and we've thought a lot about, who are the people who are actually going to be helped by this. So I do think the offline meeting, Morty, you suggested is that's a really good idea. When we've got the things that have been raised out, I will circulate them to everybody that is here today and ask you to come back quickly. Then we'll put the meeting that I think it would be good to hold at Clover Street together so that we're getting that direct link into the ICB with a particular focus on the hub for Medway, whatever shape that takes, because I think the issues that Martin raised were really important. And, you know, and with Health Watch, let's invite you along so that we can think about, you know, is there a piece of work that you could usefully do that would add to this situation. So thank everybody for your frankness, the stories that you've shared today. That was really helpful. So we've just got one more item now, which is the work programme going forward. Steph.
I'm not going to go through the whole work programme. I expect everybody to have, you know, read it, and happy to take any comments, suggestions, anything really.
Yeah, thanks, Teresa. I think we're all practically perfect in every way, aren't we? So there's a Mary Poppins reference in there somewhere. Just on the work programme, just picking up on the two issues at the end there, the climate change action plan and the local plan. The climate change action plan isn't due for publication until next June, so there's plenty of time to incorporate that into the timetable. The local plan goes out to its public consultation phase B shortly after the election. So and that will go on into sort of September time, I suspect. And then it needs to get out to its regulation 19, which is the examination by an inspector early in the new year. So it might be helpful to try and get it onto the agenda before the end of the year in order for the planning officers to talk it through, and particularly in terms of the development, the infrastructure development plan around the growing population in Medway that's going to come through. So particularly important that we get that in, I think, just to mention.
I think the main thing for me was trying to speak to officers to find out, to discuss what that will look like for Health and Wellbeing Board, because it's already going to all the other ONSs. I don't want it to be a repeat, if that makes sense, of what's... So we need to have a discussion as to what that will look like for us.
Yeah.
It was just a final thing, and I don't know if this is conflict of interest, but I just wanted to put it in. I am involved in Menopause Cafe Medway Towns, which is a national not-for-profit organisation aimed at helping menopausal women to get together, just to chat, share their experiences in a non-judgmental way. And we've got one this weekend on Saturday, and that's at the Pantry, Fort Amherst, Chatham, and then we're going to hold one every month going forward, and we're going to put it around the Medway towns. And as I say, I stress it's non-promotional, although I'm a menopause specialist, and there's a lady who's a menopause coach, and there's also somebody from public health. We're doing it because we want to share experiences and get women together, and I'd like to, you know, extend that to all sorts of people, and maybe even focus on diversity groups, culturally. So I was going to talk to Rupa, but if you're interested, you can take a poster, and it's got a QR code. So please take one. That's for June, and that's for July. And thank you for letting me say that. Thank you. There's two.